our institution. And there are also other key members and team members, and I'm not going to really talk a ton about some of these projects, but I am going to highlight a few of them as it relates to the work that we've done. But I always like to start my quality talks with this quote: "Quality is never an accident. It's always the result of intelligent effort." And that was done, a quote by John Ruskin, who's an early 19th century philosopher. I also like to quote Wayne Gretzky, a hockey player. He says, "I skate to where the puck is going to be, not to where it's been." And I think that's a really good lesson for all of us as we do our work in neurology. So let's talk a little bit about quality measures. The definition is here, and I'll let you guys read through that. But basically, I want to summarize what a good quality measure is. Quality measure takes good, solid evidence that something should be done in practice, and then pairs it with that perhaps it's not being done. There's evidence to suggest there's a gap in it being implemented. And that then makes for a good quality measure. And so a lot of the quality measures that we're gonna talk about today from the Academy are kind of under that premise. But there are three types of kind of measures that most people are familiar with: structural, process, and outcome. The biggest thing for you guys to know is that outcome measures are obviously the one where the rubber hits the road. This is where the patients get better. So for the example listed here, it's infantile spasms remission, right? That's what we care about. But it's also important to make sure that you keep track of other type measures, meaning that, is there an opportunity to make sure there's not harm being done elsewhere in the system because of the changes you're making? And we call that a balancing measure. So one thing to say about the AAN quality measures, which I do a lot of work with, is it's not guidelines. They're different. Guidelines are the evidence, or the way we say things in the literature guide our care. But the actual measure, again, is that it's paired with, okay, for whatever reason, it's not being implemented. The cycle of the quality measures is pretty complicated and complex. I'm not going to go through all the steps, but I want you to recognize that this process is very in-depth in the sense that it's detailed, it's methodical, there's a lot of process and structure behind it. So when you see these quality measures, you'll know that there's been a lot of time and effort that went into making these and updating them. So we're going to focus obviously on epilepsy, my passion and my area of expertise. And I just want you to be aware of the 2017 quality measures set that had some of these measures here. Since then, there's been a new publication around seizure frequency that allows us to not only just measure it as a process measure, which are the steps it takes to put it into place, but the actual outcome of improving or maintaining seizure frequency in all our patients with epilepsy. The other measure set that I want to bring up, because we're going to talk about, are the child neurology quality measures, because some of them have epilepsy-related measures in them. These are currently being updated, and the new slate of measures we hope will be available in 2023. So I love being able to take quality measures and then using quality improvement methodology to implement them. And for those that have done quality improvement during your residency and your training program, you will understand that what they do is allow us to develop factors that are necessary to be changed for us to actually improve on the actual measure. And then we develop the interventions, which are going to be the steps it takes to actually address those barriers or address those factors so we can be successful with our measure. And that's what we've done over time in several examples that I'll highlight today. So why did we focus on emergency department visits as outcome measures? Well, if you look at that for epilepsy, many of them are actually preventable. They add a lot of cost to the healthcare system. Nobody's happy. You guys aren't happy when you have to go to the emergency department to see a kid or an adult with, a seizure, because it could have been handled in the outpatient office. The doc in the ED isn't happy because, they're clogging up the system and they have a person there that needs to be there. The neurology attending's not happy because they're like, oh my gosh, we could have done this in the outpatient setting. So that's actually how I got started with all this. It was dissatisfaction in multiple people, and said, well, let's try to make it go away. The other thing you need to know about epilepsy, if you don't already, it's what we call an ambulatory sensitive condition, meaning that the care we give our families and patients with epilepsy or people with epilepsy is actually better in the outpatient setting. And that really is a good opportunity for us to actually implement good high quality care, do education. It's not as anxious as a setting. It allows for continuity, different access to resources, etc. The other thing what we learned about ED visits and seizures is that if you are somebody who've used the ED before, you're likely to keep using it. If you're somebody on Medicaid or government insurance or low socioeconomic status, you're unfortunately more likely to use the ED for your care. You're also more likely to use the ED if you're not given a rescue medicine or the rescue medicine isn't dosed properly. And these are, again, proven with medical literature and studies. And my references at the end, so you guys can take a look at them. You're also more likely to use ED if you don't have a lot of knowledge about what to do for a seizure or the steps of handling a seizure in your home setting or for your loved one. And lastly, you're going to be more likely to use ED if you don't take your anti-seizure meds, which makes sense. The other thing, which I won't belabor, is what's the impact of somebody coming into the emergency department and then getting admitted, right? Like that's not a good ideal situation for anybody in their care. And so we'd like to try to prevent and avoid that. But let's focus on ED. And let's talk about a little bit of the costs. What we know about epilepsy is it's a very expensive proposition. And again, our healthcare system is fragile in the sense of we do spend a lot of money, and if there's opportunities to save, but also provide high quality care, we should do so. There's also disparities, unfortunately, in our care of epilepsy patients. And I won't highlight some of that, but the unfortunate part is that we have to do better about recognizing these disparities and triggering interventions to help. And so that's some of the work that we're kind of trying to do now and address. So I really believe in the triple aim of healthcare, which is an IHI or Institute of Healthcare Improvement proposition. And I kind of mentioned it, but it's really to improve the quality of care, improve the health of populations overall and decrease the costs. So I started this work on one patient that was using the emergency department for their epilepsy in a large, significant way. And the hospital system said, hey, can we do something about it? So PFK, for those on the call, is our accountable care organization. So we have a sister organization that allows us to provide care for patients on Medicaid in Central and Southeast and Central Ohio, or West Central Ohio. And what we do is we, regardless if they've come to us for care, we pay their medical bills, we provide care coordination, and do a lot of other resources. So that person was in that system. So we use the IHI model, which is the improvement model I hope you're familiar with, that's broken down into these three buckets. And we made this as like a pilot almost, or what we call a PDSA, Plan, Do, Study, Act cycle, where we just started with 4 kids who were using the emergency department a lot for their epilepsy care, just to see what we could do and what we could do for their costs. And really, we used the quality improvement methodology, developed our drivers and our interventions to see what we could do and see if it could work. At baseline, you could see these visits. Now, obviously, I'm not showing you this information to demonstrate statistical significance, but I'll get to that and how that informed our future work around QI. But they did have high utilization. And they also had high costs. But after we did some interventions without too much effort, we saw a 76% reduction. What that taught us was that perhaps we're onto something and we could do it on a bigger scale. And that work we started back in 2011 and 2012. So when I first was at Nationwide Children's, we also reduced their costs. So meaning these kids were now no longer spending or contributing to the healthcare system as significantly as they were the previous year. So that then led to this huge project and undertaking that took multiple team members and efforts to see what we could do. And then we broke it apart, as you can see in the slide, amongst different sub-projects to see if we could really make an impact and overall try to decrease the number of hospital days for kids with epilepsy who came to Nationwide Children's. The biggest things that were successful, and obviously also decreased ED visits, because that was a big bucket. What we found was that half the kids who came to the ED got admitted. So if you could prevent the ED visit, obviously you're preventing the admission because they're not going to be there. We developed an urgent epilepsy clinic, meaning if somebody was met certain criteria, where the parents seemed anxious on the call to the nurse, or they were having lots of seizures, or they were out of medications, or certain other factors, we said, hey, can you come in and see us? And these were like blocked appointments that the nurse practitioner and a social worker had, so we could kind of go through the barriers and then kind of address that. We also were able to hire an additional social worker, which I know is a resource that many don't have. But I will tell you that this work helped advocate for hiring of those people, which are important to our success. We standardized education. We looked at those risk factors to see if we could predict who's going to come in. And then we also embedded our pharmacist into our clinic to see if that person could help. And I'll talk some about that. We also decided we'd create a seizure action plan, which we published, and it was modeled after the asthma action plan. So then we said, you know what, we're going to keep going, and we're going to try to see if we could do better than what we had done. So we kept this work going over years, and we're able to actually decrease the number of ED visits per thousands of patients. And we said, hey, you know what, we're going to even improve upon that more. So we focused then just on the ED visits, because again, we felt if we could prevent that, you could prevent the hospitalizations. And what we were able to do is to kind of retool some of the interventions. We kind of had taken our foot off the gas, or maybe not paid as much attention to the project because we thought we were doing okay. And then we realized we had to focus again and try to do more. We also decided to look at demographics because of some of those disparities to see if we could see what patient populations were affected the most. And what we noticed was that majority of our patients were on Medicaid. For us in Ohio, the state of Ohio has a really good Medicaid program. And so you can measure, who is on that program. So that accountable care organization I mentioned earlier was very key because 51% were covered by them, which meant they could actually get involved and be helpful to kind of contact these families. One of the nice things was that we brought this team together and said, we're going to have huddles every week. So we could then address individual issues. We actually still do that. So today at 11 a.m. Eastern, I'll be meeting with the team virtually, and we're going to go through everybody who's come into the emergency department this past week to see what opportunities exist to prevent future ED visits. Remember, I mentioned earlier, one of the risk factors was if you use the ED, you're going to likely use it again. And so let's target that. The other thing we did was we started to look at rescue meds. We realized that even though it wasn't a high percentage, there was some percent of patients who weren't given rescue meds, or it was dosed too low based on evidence. And so we said, you know what, we're going to target that and have our pharmacist do that. And then we also said, you know what, a lot of our interventions are in the clinic. So no-shows became very important. If you're going to miss an appointment, you're not going to get the benefit of all the education, all the stuff that we do in the clinic that I mentioned earlier. And so we said, you know what, we're going to try to target that and see if we can decrease our no-shows, or what we really want to do is bring kids and their families into the clinic for opportunities. I want to highlight a little bit of the PFK Care Coordination because, care coordination, I think, is an important opportunity that I hope can be expanded based on some of the work that we've done and others have done. And really what you can do with it is allow partnerships with either insurance companies or other entities like accountable care organizations, like I mentioned, to actually successfully reach patients that you otherwise probably couldn't get to. And I think that's an opportunity that we have to explore. I mentioned the huddles or the weekly reviews, which I'm again going to do. And one of the things we realized was there was themes that start to arose from these huddles. And they were that 30% needed more education. They just didn't know or felt comfortable managing the seizures. Anxiety was an issue. And then schools. So we had an opportunity to work with schools to say, hey, you don't have to keep sending these kids to the emergency department because they had a 2-minute seizure. Or why didn't you give the rescue med? Or what education do you need to give the rescue med, et cetera? So a neat opportunity to reach out into the community. Let's talk a little bit about the pharmacist, because you don't necessarily have to have a pharmacist to do this work. Each and every one of you during your program and your work seeing epilepsy patients could do this. Make sure they have a seizure action plan. There's some good publications that we just recently did nationally around what goes into a seizure action plan or what should be included and how to make one. The other thing is talk about the side effects. I think we underestimate the number of side effects that patients have with epilepsy medications, and that could be an issue. If they're going to have side effects, they may not take their medicines. And if they don't tell you that, then how are you going to know? And then make sure they have a rescue if they're at risk for prolonged seizures. Even in the adult population, that's really important. We now have some commercially available medications that make it easier to dose or to give. And so, you don't have to use those, but you want to make sure they have something. The other thing about it is, we wanted to be proactive. And so we started again targeting schools to make sure they had the seizure action plan. For, adults, obviously they may not need that as much, but they may have a benefit of having a seizure action plan for their work setting or even in their home setting where their loved one knows what to do. I mentioned the no-shows, and one of the things that we realized is that we could predict who's going to no-show. So we developed a predictive algorithm and published that to say, hey, you know what? Are you at risk or high risk? And then what we did is we did what I call a full court press. We had our social workers call, we had our PFK Care Coordinators call, we had our administrative assistants call. But we didn't say, hey, we just call and remind you have an appointment, because that's not going to be as helpful. We said, hey, you have an appointment coming up. What barriers exist for you not to be able to make it? Meaning, do you have a car problem, transportation, other issues, childcare? What can we do to try to help get you to the appointment? And what we also learned was that then made it a more feasible for people to feel comfortable coming and wanting to be a part of our team. So they felt like there was going to be something done at the appointment. One of the things I teach my trainees is that if you don't have a purpose to their clinic visit, people are more likely not to come. So have a purpose and make sure that you tell them that purpose and remind people of that purpose. So if you aren't familiar with control charts, they're a great way to demonstrate statistical significance in quality improvement projects. They use scientific and statistical methodology that's developed by a group called the ASQ. And what you see is a shift downward is what we want. That's the desired direction. And so over time, this work has led to continually decreased effort or decreased ED visits for people with epilepsy. I do want to highlight all the interventions that took place that I mentioned today. And that unfortunately I went through very quickly, but I hope that you have an opportunity to look at and see if you could potentially replicate. It's been very successful and very helpful. But then I do want to highlight something that maybe you have heard about. There was this thing called the COVID-19 pandemic. I'm not sure if you're familiar with this. And if you dial into our data, you'll realize that our ED visits tanked during the beginning of this pandemic. And I'm sure you saw the same effect in your institutions as things changed and we went to, all home care. So we said, you know what, we got to look into this and figure out what factors exist. There are some studies that have come out that looked at this and saw the same thing, and not just in the United States, in Hong Kong and Italy, but they didn't really see why that was occurring. I mean, we have our ideas, and I'm sure you have thoughts as well. But what we really wanted to learn is not, that it happened, but what can we learn that might actually help inform continued decreased visits? And we realized perhaps these were some of the reasons. Well, we're not going to keep schools closed. We're not going to keep people distancing. But what we realized could perhaps an opportunity if you improve the health and overall well-being of your families and your patients with epilepsy, could you then prevent seizures, right? What is a big risk factor for breakthrough seizures or status epilepticus if you have epilepsy? Getting sick. So that was an opportunity that we're still trying to figure out. So we're looking at that. We have a huge database that I mentioned from that list review that we do every week. And we're looking at to see if there's proactive models for prediction that we can implement or other risk factors. But then we're also going to look at pre versus post-COVID. Finally, though, we're going to take this huge database of thousands of patients that we've tracked over years to see if we could identify those disparities a little bit better to see if that could inform future directions. So it's been really exciting work, but not complete, not done. So I have residents, medical students, social workers, bunch of people working on this. And so it's a really great opportunity for everyone to be involved. And I love it because it's a team effort. And it's all because of this model, the improvement model, recording improvement. One of the themes or ideas and reasons why I love giving these presentations to you guys is that I want to inspire, and I hope it does, that you can do quality improvement. You don't need a prospective research grant. You don't need like tons of time. I mean, you do need some time, but everybody can do something. And it just takes a little change. And you can just start small like we did. You don't have to do a huge thing. Just pick a few patients or pick a day in clinic, pick a group of people. A lot of our projects, we start with the residence clinic because that is a great opportunity. And you guys are always so eager to do good. And I think that's an admirable thing. So I know I flew through that, but again, I apologize because I do want to leave time for questions and conversation, because that's actually one of the things I think is most beneficial in this setting. So I will stop and open it up to the floor for questions, thoughts, comments, or just conversation. Yes, Dr. Ghosh.
Hello, Dr. Patel.
Hi.
Oh, sorry, my video. There we go. All right. So, question for you. I know you mentioned that the residents are always very enthused and always wanting to do good. Sometimes there's also the flip side where like we have to do a QI project for graduation. This is irritating. But are some residents who are genuinely interested in this, but as they become attendings, it seems like the enthusiasm somewhat fades, mainly because I get the sense that there's nothing, as compared to like research, there's tracks and things in place to incentivize junior attendings to become researchers. There's KL2 awards, there's grants. Is there anything along the lines of trying to create a QI researcher, something that like, because you do need some protection, especially as a junior attending, trying to do all this work on top of your clinics, on top of everything else you have. So is there any mechanism that's in place currently or soon to be in place that can help junior attendings or residents who want to develop that into a career?
So I promise you, Dr. Ghosh is not a plant or a question. But I am so excited that you asked that. So part of my fun work is I'm the vice chair of the quality committee for the American Academy of Neurology. And the quality committee has just started this endeavor because we recognize the gap that exists in exactly what you just said. We have this passion, we have this energy in the residency, and exactly what occurs is there's nowhere to go. There's no mentorship, there's no opportunities. So we at the quality committee and your Academy of Neurology are going to create that for you. So what we're going to do is we created a work group led by Dr. Liz March, who's at Johns Hopkins in Baltimore. And we got a group of people together, and we haven't had our first meeting yet. But I encourage that we stay in touch, because I want you to participate or help us with these efforts and get involved with our group. Because what we're going to do is try to figure out how we can create that and how we can pair in mentorships. The other thing is AHRQ has some mechanisms they're developing around this idea. They're more broad and they're not necessarily neurology based. And so that's one of the problems, but we're going to try to focus on seeing what tools we can bring in from them. The third thing is that which I didn't talk about today, and I'd love to come back and talk to you guys about learning healthcare systems and their utility in epilepsy and neurology care. Last week, we had our Child Neurology Society meeting, and we presented this as part of a symposium around quality of care. But in that symposium, we talked about the two existing learning healthcare systems in epilepsy. One that focuses on all ages, and it's run by the Epilepsy Foundation, and the one that I'm part of, the Pediatric Epilepsy Learning Healthcare System, that's actually housed out of Cornell near you guys. And we are going to come together, and put a research grant around this purpose, to where if you participate in the learning healthcare system, perhaps we can develop some mentorship programming and protected time for the faculty to be able to do this protection. So again, look for these opportunities, but those are the things that we're going to start and try because we recognize those gaps. Every year at the Academy, when I talk about quality or I do a presentation, I usually have somebody coming up and asking me that question. And so that's why we decided that we tackle it. Now we are open to other thoughts and ideas. So again, let's stay in touch, specifically you, Dr. Ghosh, because if you'd like, I mean, I'd love to get involved or get your feedback on some of the stuff we're developing and see what we can do. So I hope that answers the question, but that was a little.
No, definitely. Thank you for that.
You're welcome. Yeah, I get a little passionate and soapboxy about that one. So again, he was not a plan. I did not ask him to ask me that question, but all right.
Yes, sorry, Dr. Brian and Ziska. One thing that seems to be missing from all the QI projects is that somebody else, social workers, pharmacists, etc., assume responsibility. What about the patient being taught agency? I mean, epileptic patients, many of them are really responsible for themselves taking medication, for turning up at clinic, for not making unnecessary ED. They can be trained or educated to take agency and to, decrease the kind of load on everybody else. I mean, hospitals are short of social workers, they're short of pharmacists, they're not short of administrators, but they're short of everyone else, doctors. And the patient is really the pivot, certainly of epilepsy. And so they have to be taught agency like anybody else.
Yeah, I agree 100%. I think that part of our role is to empower our kids, our families, the people with epilepsy, but then also partnering with the Epilepsy Foundation and other advocacy groups. So part of the learning healthcare system model is actually incorporating those aspects into the care. So utilizing resources that currently exist at the foundation, but also involving families and people with epilepsy. So every successful learning healthcare system involves patients with epilepsy, and we learn from them, but they learn from us. But the sense of how that learning can translate to empowering others, to do the right thing and understand the implications of that care. So absolutely, and that's definitely part of it. Hopefully, once we start to do more with the learning healthcare systems, we can get that information out there, and that can then hopefully be expanded and replicated because of that resource issue. You're absolutely right. All right.
For example, there's muscular dystrophy. There's a parents project in muscular dystrophy in which families run. They actually invite speakers, and they are really driving this particular, if not the usual MDA thing. And we need something in epilepsy similarly.
Yes. No, you're absolutely correct.
The layman should take major responsibility.
Yeah, and I hope that that'll happen over time, and you'll see that.
May I comment?
Yes, please. Yes,
Yes,
please. And then there's one question I want to answer in the chat, but go ahead.
Okay, wonderful. Because I don't know, Dr. Francisca may not be aware of some of the initiatives that we actually to be able to partner with patients better participate in their care. We have actually in PZNR, we have a rescue med quality project for making sure that families all have that. In both the pediatric and adult neuro, we have a prescript. We actually discovered that we as physicians were having issues writing prescriptions properly, some of it because of Epic. And we've been doing a wonderful QI project in our clinics to see where we screw up and to really put in checks before we sign off on anything, that we get the prescriptions right. And we've had a decrease in prescription errors, which was phenomenally high. Some of it is because we're still dealing with a new medical record system, which does not make it easy. And then we also have a status epilepticus QI project that we partnered with ED and ICU as well as neuro in both adult and children. And then I love your epilepsy clinic missed appointments comment. That's we're going to start a new one. Because I think that, all of what you're talking about and what Dr. Francisca is also talking about is we're trying really to help the patients and their families really manage their disease that's oftentimes lifelong, and really setting up these partnerships to really improve what we're doing, and our subspecialty clinics or practices, whatever you want to call them, are really enabling us to do that. So it's exciting to see what you're doing, and we'll learn from that. And
well, and I can't wait to learn from what you guys are doing, because all of what you just said really makes me happy. We just published the no-show paper not too long ago, I think in Journal of Child Neurology. So, if that helps you, great. But all those efforts that you're doing are so helpful and important. So kudos. I think that's awesome. I do want to answer the question in chat and then continue talking. How do savings from not visiting ER compare to costs of running a clinic with physician, pharmacists, social worker, transportation, et cetera? That's an excellent question. So when we really looked at the analysis of both the ED visit and the hospitalization, and then compared that to the actual additional costs, we still had cost savings in the healthcare system. Now, largely because the social workers pay their salary. Sorry, let me say this the right way. Obviously, they don't pay their own salary, but they don't make a lot of money. And I don't want to get on social commentary about they should deserve more money, because I think they do. But because they're not an expensive resource, I took the finances to our chief financial officer at the time and said, look, we saved $180,000. A social worker's salary is $50,000. What could we do if you gave me more? And then that's how we kind of got started. So even when you account for the overhead and you account for all these extra services, as long as you incorporate that as much as you can into your daily flow, it's just coming down to time, and you'll still have cost savings. Now, in a fee-for-service model, there's no savings, meaning our hospitals make money when we either mess up or people come, and if they stay. So when I talk about cost savings, I'm talking about a value-based care proposition model. And because we have that accountable care organization, the people who run the finances have to look at that. I'm not going to, again, make a commentary on, is that a good model or a bad model? I think it's a good model, because then we have skin in the game, and we also want to do the right thing, right? We want to provide the right care. So I want you to think about this as a bucket of money. And that bucket of money, I know you don't have direct control over, but I want you to think of it that way in all the work that you do. And let's use that bucket of money to the people who need it. So for example, if you need epilepsy surgery evaluation, that's a large amount of money that's going to be expended. Now, study after study has shown that eventually that is a cost savings down the road. But let's take that bucket and say, okay, you need this amount, but those people who you don't need it, let's not waste it there. And that goes back to that empowerment thing we talked about earlier in the question earlier, and some of the work that you're doing. So that's where I look at costs and how it can be saved. But yes, it is still advantageous in a value-based care model to do this work, even if it ties up some extra resources. Great question.
I have a couple questions, if I might. Hi,
Yeah,
Anup, it's
please.
Susanna Okula. Thanks for such a great talk. I wanted to hear a little bit more about the seizure prediction algorithms that your group has developed. And then also, the talk is just a great narrative of success, but I wondered if you could share also for our residents any obstacles you faced in developing these projects, and how you liaisoned with other disciplines, other roles besides physicians to try to overcome them, or any kind of QI failures that you've had, because I think it's easy to look at all the successes, but we're involved in QI track here with our residents and education. So just trying to sort of troubleshoot different projects, or when to scale up or let your project kind of go.
Yeah, excellent questions. And you know what? You've just given me an idea that I should probably incorporate some of the failures. But let me first talk about the first part of the question, and then I'll definitely address the second one. The prediction model, we're still kind of working out, but one of the things that we, there's three different types of prediction models that we're working on. One is, can you actually predict seizures, or when you're going to have worsening of seizures? And that work is largely not done by us, but led by my friend and Robert Moss, who runs Seizure Tracker. Seizure Tracker is a non-for-profit seizure diary, but they also collect a lot of information and are partnering with some data scientists to see if they could actually predict those kinds of things. The other group that's working on this is the neurostimulation groups that are looking at RNS data to see if, again, there's some signatures there to predict. So, for example, could that data be fed back to the family or the patient or the person with epilepsy and say, today might be a bad day, or, based on your algorithm, you may just want to be a little bit more cautious, or perhaps maybe take an extra Klonopin bridge or something. The other two predictions are ED visits. And we did some work with Dr. Grinspan up in Manhattan. And what we did was there's two studies. We looked at the New York area. And so he had access to all epilepsy patients, children mostly, who went to multiple different hospitals in New York. You guys, there's a different dynamic because we know everybody in Ohio or Central Ohio are going to come to our ED, so it's easy to do that. He had to look at all these different ones, and then we replicated that same sort of predictive model to see. And really, the biggest thing that came through was if you had 4 or more ED visits in 1 year, you were likely to have at least that or more in the next subsequent year. The other big risk factor was if you were on Medicaid or Medicare. So if you had government insurance of some sort, you were more likely to be in that risk. So that's kind of how we developed the algorithm. The third one was around no-shows. And what we were able to do is take a bunch of factors and give a percentage score of what's the likelihood of you no-showing. So what that allows us now to do is to say, if you take the list of people who have an appointment, and we do it a week prior. So, 1 week prior to there's a list that comes out and say, in the subsequent week, Johnny, for example, has a 67% chance of no showing based on these factors, which again are very similar to, did you miss appointments in the past? Are you on government insurance? There's a couple others, like, I forget the specifics, but it's in the paper there. But what it allows us then is to say, okay, let's say I only have like 15 extra minutes, I'm not going to target the kids at the lower end of the list. I'm going to start on my way top and go all the way down to see if that can work. And so that's kind of how we're now trying to approach that work to see if it could be helpful. The other part of the question about failures. So one of the beautiful things about QI, it's all about failure. And you fail fast, and then you learn from that. So if you don't make a huge change to your system, then you can then go back and change it. So I'll talk about a couple failures. One of the, a failure that then we had to kind of turn into a success. Motivation can be a failure. How do I get all my colleagues and people to do what I want them to do? You can't just tell people to do stuff. You have to show them. And at first I thought, oh my gosh, I'm just gonna show these 4 kids and everyone's going to do the right thing and life will be happy. And, and that's not. Okay. One of the failures that we turned into a positive was repetitiveness. So reminders at faculty meetings, sending emails occasionally that says, hey, here's your performance or here's our success. That's how we turn the failure into success. Another big failure was really underestimating or maybe overestimating the importance of education amongst seizures. We thought we did a good job. And when we got feedback from our families, meaning what we call teach back, we were poor with that. And so we had to revamp what we had to do in that sense. And that we wanted to standardize it and really try to leverage, again, some of those other resources I mentioned, like the Epilepsy Foundation. We have an Epilepsy Alliance, those things. The other big one I would say is around seizure rescue meds. So what we didn't account for when we put in the seizure rescue med algorithms was the change to these newer products. And so when you don't pay attention to change, you sometimes keep things going, unfortunately, and you don't catch those errors. So we started to see an uptick because we hadn't built our systems to be sustainable in the sense of, okay, now there's these new commercially available medicines. So those are some of the failures that we turned hopefully into successes. But excellent point, and I definitely want to start to put that in there because fail fast and fail often it's been a long journey, but yeah, there's multiple frustrations. I could probably spend a whole hour on that alone, but I think we have a question from, it says Peds Neuro. Do we have a Peds Neuro? Lakshmi, are you Peds Neuro?
Hi, Dr. Patel. I'm Lakshmi. I'm one of the Peds Neuro residents. Thank you for the wonderful talk. So we have a QI project currently running in our department, pediatric neurology, regarding improving seizure rescue medication, especially the intranasal medications. But the significant obstacle that we are facing is insurance related issue, cost of the medication. Certain insurance does not approve the medications, and they're asking like around $300 copay for the medication, which is actually a huge obstacle in our study. But we did see improvement in our study in prescribing intranasal rescue medication. But do you face similar obstacles, and what are your opinions in outcome what are your opinions in regarding the insurance issues and the obstacles similar to that? Thank you.
Excellent question. And yes, we do have some of those same issues. So one of the things we do in that situation is we prescribe 2 different forms of rescue meds. It's $20. They're not as easy as the commercially available, and they have to be obtained by our pharmacy. But if you have somebody at your pharmacy, we can get them connected to ours, so they can teach each other how to make these available. There's 2. There's a vial of midazolam, and then a syringe and what we call an atomizer, which is a little mushroom cap, and that total is $20. You can also, but your pharmacist will have to do this, get the midazolam in a pre-filled syringe. And so then all they have to do then is put the atomizer on top. We created, which we're happy to share as well. We created magnets of instructions of how to actually do this, put the kit together, and how to give it to families. We also then have it on our seizure action plan as an option because of that barrier. The final thing we're trying to do, which is never easy, but let's go back to this: how do we empower others and advocacy? So I am in constant conversation with the 2 commercial companies that have now made these products and charge an exorbitant amount to say, you guys are hurting us, and what are you doing to help? And so we're going to consistently bombard them until they start to help that. And they've done some stuff with copay cards and cost reduction programs and stuff like that. But ultimately, when the insurance company says denied or large copay, we kick it into these other things. And it found it to be very successful. So yeah, if you have a contact, email me, and then I can connect you with Jim Herbst, our pharmacist who led this initiative.
Thank you very much. That's interesting.
Yeah, $20. And I'll be honest, that's also not economical for every family and every person with epilepsy, but insurance companies tend to approve the $20 one. So we have not had a situation, knock on wood, that a person with epilepsy is going without rescue med when they need it. I will say the Epilepsy Foundation in our state did advocate for Medicaid to cover the commercial products. So that's yet another effort too, is reach out to the foundation to see if they can get at least the government insurances to cover. They were successful here in Ohio doing that. And again, I'm happy to connect you with that person if needed to. It's a team, right? Like there are too many things we got to do and not enough resources. Oh, email address. Absolutely. I am going to put it in here. And Fatima has it as well, but I want to put it in here too. And I know we went over time, and I apologize again for messing up the time. But thank you for your attention. Thank you for your questions. And I want to learn more about the work you guys are doing, and so we can learn from each other, because I think what you're doing is amazingly great.
I think this was an amazing talk, and we all learned a lot. So thank you so much for sharing your experience and your ideas. And I don't know if there's any other questions. Did I interrupt somebody? Awesome.
The last thing I'll say is please you can share and send my slides around. Because again, I know I went through it very fast. So if they're of value of use or somebody wants to look at them, please feel free.
Sure, I will. And I'll share. Is this okay if I share your email address too?
Absolutely. Yeah.
Sure.
Oh, shucks. I think I just sent it to Dr. Ghosh. But yes, please share it with everybody.
Sure.
Yeah.
Thank you very much. And yeah, I mean, we really enjoyed it. So.
Great. Thanks for having me. And again, I'm sorry I was late, messed up the
No,
time.
that's okay. Thank you. Thank you.
Have a
very
great
much.
day, everybody.
Thank
Bye.
you. Bye.